Test 1 2, mic 1 3, test.
Good. Okie dokie. Good morning, everyone. Thank you for being here. We have the Joint Finance and Planning Board, and we do have a quorum, so we should be fine. I'd like to entertain a motion on the minutes from the last meeting, please.
Move approval of the minutes.
Motion from Dorothy, second. Second from Zim. All right. Any questions? If all in favor, say aye. Aye. All opposed, same sign. That motion carries. Thank you very much. And we're going to try to be concise today, not because we're rushing anyone, but because we have important events going on. This is like the second to the last week of school before finals. So lots of award ceremonies going on. Lots of parents need to be out there helping kids celebrate. So we're going to try to make it as concise as we can. And with that, Sharon, you're one of those that's going to be going to congratulate your kids today, I know. So welcome.
It's good to have a senior. So one down, one to go.
There you go.
So thank you for that. I just have a couple of big updates today. I think the largest one we alluded to at the board meeting, but CMS actually approved the payment as suggested by HHSC for the CHIRP and the TIPS program. It's kind of a replacement for DSRIP. We get a small payment on every patient claim through our Medicaid managed care. And so although we have not started to reprocess the last 6 months of claims, we did accrue for that this month on the financials when I go over that. The second big announcement came about a week ago, and CMS has also approved the 10-year plan for our uncompensated care.
Well,
That's a 10-year renewal. It is about $120 million for our institution. So it's a really large payment. And again, that's a 2023 start. So we will have that program for the next 10 years, which is a huge win for all the hospitals in Texas.
Good news.
The next two are not as exciting, but I know that Roger last time asked for kind of a year-to-date or live-to-date update on some of the COVID relief dollars that we have been able to obtain throughout the last 2 years. As DT and I walked through that, he suggested that we bring that back to the full board so that everybody could hear that information. So we'll work on getting that on the agenda for the next board meeting in a couple of weeks. And the fourth item is that DT and I are working on kind of refreshing the slide deck that I go over with you guys every month at this meeting. So next month in May, you'll likely see some new slides, hopefully a little bit more condensed presentation, and giving you a little bit more information. So it's a work in progress. I don't expect that to be like the final outcome. So be ready to hear about some different things. And then we look forward to hearing your thoughts on things that you're missing or things that you would like to see. So that'll be a little bit different next month. So I'm going to go ahead and head through the financials.
Okay.
Again, our statistics don't look a whole lot different from last month. We have seen a bit of a bump in volumes from the prior month in February, but we do have a couple of extra days in March. So that accounts for some of that, but we did see a slight return. And our length of stay is down at the bottom right, has decreased slightly. So that is kind of a bit of a difference, but it makes a big trend through our throughput numbers. Our outpatient statistics, the ED, you can see was relatively high in March compared to the other months in this year. And our primary care visits were right on target, and our specialty clinic visits were a bit above budget for the month. On some of the others, at the bottom of the page, you can see that our inpatient surgeries, they were higher than they were last month. And then our outpatient surgeries, you can see at the bottom right, have really increased. A lot of work is being done on the throughput of surgeries. We're trying to maximize the effect that opening back up our Arlington Surgery Center has had. So lots of logistical work around the outpatient side, and you can see some of those impacts this month. Yes, Dorothy?
What's happening with observation cases? It really spiked that.
So recall that we've got, all of the February and March are a pretty good gap. We've got actually 3 extra days relative to February. But our observation cases, there are also work groups that have begun discussion of our OBS cases as far as appropriate classification, starting with documentation and our EMR. And so I think over the next few months, you'll start to see some of those observation cases go down, and they'll kind of show up on the other side with an increase in the admission number.
Can I ask a question? I don't think that it necessarily revolves around finance, but it just comes to my head when I see emergency visits down, urgent care is good, specialty is good, and primary is okay. Besides financial, what do we glean for that? I mean, we always hear that the emergency room is full and overrun and so busy, but it doesn't appear that it is. I mean, to me, it kind of seems that the system's working, like it's what we want, right? I mean, maybe not financially, obviously, but
It's hard to look at these in the moment, because remember, these were all budgeted based on previous years that determine what that volume is. And so, the actual does not necessarily speak to how busy it is. It's just how we budget it for that month.
Okay.
Does that make sense?
sure.
But
No, they're still seeing over 300
yeah.
in ED, so they're pretty busy, you know that.
All right.
I have one more question. It's on inpatient surgeries. They continue to go down. Is there something happening that we need to know about, or what is the plan? Because that's a statistic that haven't looked like it's going down a little bit more.
So Dorothy, on the inpatient surgery, it's stayed fairly constant. I think November was a fairly low month, but it's stayed kind of on track this for the last 6 months relative to the trend. We have not achieved what was budgeted. Again, if you look at the budget, it's actually higher than the 3-year trend, but I can get some more information and bring it back to you. One of the slides that I'm starting to prepare to show next month is something that you had asked for as far as like what category are surgeries low in? So is it orthopedics? Is it ENT? And as we start to drill into that, I think that will give you, at least year to date, a little bit more insight as to what's creating the gap from budget.
Okay.
Obviously, looking at this, we were a little too aggressive with the budgeted surgery volume. But it has a lot of variability month to month.
All right.
You're correct.
It's, and some of you'll remember this, 7, 8 years ago, this was a function, it was never a function of demand. Demand was always there. Capacity wasn't there. We weren't able to get enough surgery suites turned. Turn surgery suites, or is it less that and more a function of a reduced demand?
So from a inpatient standpoint, part of the struggle that we've had at the beginning of the year was room availability.
Okay.
We went through a really large refresh downtown of all of the ORs. So 2, sometimes 4 at a time were shut down to get through that construction period and bring them up to just refresh overall. We got new equipment in the OR. We repaired, repainted. So part of the beginning of the year was definitely a throughput from the main facility. From an outpatient standpoint, you can see we had was some COVID activity. We actually closed our outpatient surgery, and then we were also faced with some staffing difficulties of maintaining all of the ORs open.
Because that big peak in the outpatient surgeries looked like you added some new staff that maybe increased that volume.
So again, a lot of that volume was maximizing what we could do out at the Arlington Surgery Center.
Okay.
We did move some block times of some specialties out to Arlington, and that allowed for some of the inpatient surgeries that were more acute to occur downtown. So there may be some speculation on my part right now, but there may be some acuity that had shifted out towards Jessica that freed up some OR times, but instead of doing 10 surgeries, we only got 4 surgeries done because they were longer and more acute.
Okay, all right.
Are the surgery suites all finished now?
They are.
Yeah, they've been,
They're done.
They are done. I think they opened up 45, 60 days ago.
Okay.
We wrapped up our last one in December, January. Might have been before that.
so I do want to share with the board that we see what is going on here, and it's, Sharon alluded to a lot of all the moving parts that go on with staffing, with rooms, with opening up Jessica. A lot of this, to Sharon's point, and I do want to get credit to with the surgical team and setting those expectations around the number of rooms, how we can move patients through, even the pre-surgery and the authorization, all of that, the throughput, he's been working really hard on. The Jessica volume is volume that has been traditionally done down here, that can be done in an outpatient setting. The physicians like that setting. The patients often do too. And throughput tends to be a little bit smoother at that place, and so appropriately, some of that outpatient has been moved to the appropriate place. And Dr. Becker is working really hard to keep our ORs busy as the demand continues to increase.
Super.
On behavioral health, they are trending up a bit, and their patient days, if you look back earlier in the year, because of COVID, we often were not able to maximize every bed there, so that's kind of returned to a normal operation. Clinic visits were strong. Again, behavioral health has a pretty robust telehealth component that has remained for those patients. Some of the financial metrics, I did want to point out our days cash on hand did increase. We did receive an advanced UC payment in March. Our biggest cash infusion is usually December and January as we receive the tax revenue from the county, which they collect on our behalf. And then we do receive periodically, semi-annually, some other large payments, and our advanced UC payment did come in. At the bottom right, our FTEs per adjusted patient day are favorable this year, but you'll see on the income statement, our labor costs have really accelerated for this year too. On our connection enrollment, there's been quite a bit of discussion over the last few months about this. One of the other items that I'm working on and hope to bring to you next month is maybe just a short conversation every month about what's happening in connection. You might hear from me, you might hear from one of our operational folks who we partner with very closely on care plans and management. But we'll start to talk in smaller segments about connection and try to bring something back to you each month on that population. We have been able to maintain the enrollment here. The other slide that I plan to bring to you is really the overall activity and the number of applications that we process in eligibility and enrollment. Connection is not the only program that we sign people up for. It's really the program of last resort if you don't qualify for others. So each month we're signing almost an equivalent number up on Medicaid and disability through some of our enrollment partners. In addition to this connection, we also sign folks up for the ACA plans, and I think it's important for you to see really the overall success that we have in finding people health care through that process. So that'll be a new slide for next month. Yes, sir.
Conceivably, they could be some other place in JPS or still using JPS without.
Absolutely. So if you look at our my payer mix slide, we kind of glance through this every month, but so the connection members that you saw in that bar chart comprise the 18% of our business year to date. You notice the purple slice of the pie up there, in our self-pay percentage year to date is at 15%. So those are the folks that either don't submit an application or maybe live outside the county, but we see almost an equivalent number of non-connection uninsured patients that we do our connection patients. We see double the amount of dollars in charges for uninsured. So to your point, it's not just the connection. There's a lot of other access that happens for people without connection and without insurance.
Are we able to track those who go off connection into another program? Are we able to track those that I hate to use the term lose, but.
Yeah, so, typically, unless we know the patient, there's a lot of people that are rolling off every month, and they don't follow up with us to tell us, hey, I've got an ACA plan, or I got a new job and now I'm enrolled with my employer. It would be a fairly manual process, but if they continue at JPS, we might be able to detect if they had connection, and then at some subsequent month, they would have some type of commercial plan, or, even if they rolled on to Medicare, but that would be not real scientific. It would just be for those patients that happen to have two accounts at JPS. Does that make sense?
Yeah,
I'm just kind of brainstorming.
It appears that when you look at January, February, March, same time period that COVID started lessening. So persons might be finding employment places that are offering benefits.
Yep.
Yeah, and remember too, again, so some of the, I'm going to just talk about the theory of what I'm going to try to show next month with Connection, but we're also trying to gather just through an extrapolation through the census data, what's the possible number you could have on Connection in the county. Once we determine that, that's one question that the committee had. The other question is why the decline in the numbers? So for the last 2 years, we've kind of matched the Medicaid enrollment policy where we were giving extensions to people without having to formally come in and reapply. We would call and ask them about their employment, but we had extended that annual renewal. So when you start to see that decline, last year we were actually starting to have people come in, and if they weren't filling out their application to renew, then they were rolling off the plan. So we were having more people because we were automatically re-enrolling. And then the third part of our Connection discussion, we'll have to go around what is the right number that we want to target in the county, and how do we get more participation and get out there to get more applicants. So we'll start to kind of try to peel that apart next month as well.
It'd be very interesting to track the statistics of emergency department visits of non-connection patients that are eligible for connection. Because if we're having to treat them in the emergency department, that's the most expensive place we have to treat them. If they're eligible for connection and we could have had them, with a PPE somewhere, if they were in a medical home, then, that's a population that we should be able to relatively easily track through Epic just to know what that group is. And that might be something to consider measuring, because if we can get them out of the ED into connection, we're probably going to save everybody a lot of money.
Right.
Has us looking at medical home location.
Yeah.
Because one of my concerns has been is where we're located, is that population seducing to this. That is some of the tracking that they're doing. Some of that was done in Blue Ribbon, and some of it's now being followed up. That's what Lindsley's working on with Guidehouse, right? Sharon, I think she's with Guidehouse. That process is trying to look not only at, what the historic connection populations have been based on medical homes, but what we're experiencing today and what that connection population looks like. So I know it's a variable, but we probably need to follow up on it and make sure it's being looked at, up to date. It's a good point.
All right.
Okie dokie, income statement.
So again, for the month, we had a large pickup. We did record about $9.5 million on that top net patient service revenue line in anticipation of those claims reprocessing and us getting that extra chirp payment. Each month, you'll see a smaller amount coming through as budgeted. The other large positive variance on that top section is our retail pharmacy. We are having a lot of volume in our specialty as well as the central fill. You'll see some offsetting expenses down below, but we have seen an increased utilization in our pharmacy.
Why do you think that is, Sharon? It seems disproportionate to the patient population.
Well, from the specialty, it may not be that many patients, but that's a really high charge, high cost drug.
Acuity, maybe.
So that's what's driving a lot of that. From the salaries and related expenses, we continue to have inflated salaries this year, even above and beyond what we had planned. You can also see that contract labor is high. Most of that is in nursing as well as respiratory therapy. Those people are really difficult to hire. We have had some delays in purchase service as well as just some general savings there. And then we've been able to hold on other operating discretionary expenses somewhat, a lot of travel and meeting expense that we have been able to save there. So for the month, we've realized $16.5 million compared to about an $8.5 million budget. Year to date, we're at $47 million compared to a $51 million budget. The approval of the CHIRP program brought our variance down to about $3.5 million for this fiscal year. Again, we continue to work on making sure that we are going to be hitting our budgeted operating income target for the year. From an acclaim standpoint, encounters are right on target. I know our boxes are yellow, but we're within 1% of encounters for the month and 2% of the encounters year to date. And our net operating expense per encounter is favorable at about 4% year to date. When you look at the income statement for a claim, we've got a very favorable net patient service revenue. They were also able to recognize the TIPS program, which was the physician complement of CHIRP. And we are also receiving some favorable payments. Favorable payments continue because sequestration is still suspended. And we also are getting a higher rate on our telehealth as the COVID concession continues. Salaries, we are holding positions there, making sure that those get filled appropriately. That's created a favorable variance this month of about $1.8 million. Again, half of that was due to the TIPS program. Year to date, it's favorable about $6.4 million. So if you look at our combined income statement, those numbers get smaller and smaller as I get older and older, but over on the last column to the right, you can see from a combined standpoint, we are at about a $32.2 million performance compared to budget of $28.4. So that brings us to about $3.8 million favorable as a system year to date. And that's the first 6 months of our fiscal year.
Okay. Thank you, Sharon. Any questions on your claim information or any other financial report information? Okay. Thank you, Sharon, very much. Rory has approval of 7th Amendment to the Master Agreement between Thrive Revenue Systems and Tarrant County Hospital District. Hi, Rory.
Good morning.
Yes.
We need to vote on 8.
Oh, I apologize. Yeah, if we need to get financial, I apologize. DT takes this job now. Not used anymore. We need a motion on the financial report.
Move approval.
Dorothy is a first, Roger is a second. Any question or discussion? All in favor say aye.
Aye.
Opposed, same sign. That motion carries. Thank you, Leanne. Okay, Rory, now your turn.
Thank you. Item B is a contract for InThrive. We have an opportunity for both the claim and the hospital to perform contract modeling at a different and a higher level. We have several systems now that do that, including Epic as well as Strata. And what we are really focusing on this system for is the ability to model more effectively, as well as take care of identification of denials and underpayment trends from payers. So they are a good partner for us. They have all of our claims and remittance data, which allows us to integrate very quickly and take care of those things with respect to those underpayments and denials. We did conduct an RFP with 2 respondents. Annual costs, you can see there's $184,000. We believe we will pay for this very easily with what we will find in underpayment trends. We do identify those now, but there's a little bit of leakage that occurs throughout the system that we feel like we'll capture to more than pay for this software. Any questions?
Questions for Rory?
This is the 7th amendment to this contract, so we've been doing this for some time.
No, it's actually the claims and remittances that I referenced are the first 6 iterations of the contract. This would be in addition to the original contract.
Okay, so this is something we've never used before.
We've never used this, that's correct.
All right.
Okay, my question is, once we set this up, how will you monitor it and how will we keep track of it? Will you bring a report back quarterly on it? Or so?
Sure, we can bring back report cards at the payer level, how they're performing relative to are they paying us properly, and then we can also develop some reporting that would show what's the return on the investment, how is it doing?
I just think that once we do something, we just need to have some follow-up to see how is it working, and at the end of the contract, before the next renewal, we'll be able to say, yep, this happened and at this percentage, okay?
Sure.
Other questions for Rory?
I had a question, Rory, just for my own curiosity. Is this an Epic interface, or does it work out of a cloud, or what's the data governance?
Well, the one thing that we would strongly consider interfacing into Epic would be the contractual or the payment calculation. Right now, we try to maintain that in Epic and in Strata and in Thrive. So it's very to manage all 3. So ideally, we could interface that back into Epic so it's very it's more accurate from the standpoint of what should we be paid.
So direct interface, and they don't offer a cloud solution?
It is a from a I want to make sure I'm answering your question from a cloud solution. So
for me, a cloud would be you would upload your data into their cloud where their software analytics would do the analysis.
okay, so they already have our data from our claims and payment information. So in essence, they already have it. We are now layering on the contract expected payment portion for modeling purposes, negotiations, and things like that. So they already have our data from Epic and the claims.
In their systems, right?
Correct.
But you're looking at a direct interface as an optimal solution.
The piece we would interface back into Epic would be what's the expected, and then be able to drive workflow on the underpayments into work queues within Epic.
And one final question, is the interface included in this contract, or would it require a separate contract?
It's included. We would have some development on the Epic side, just our own internal team, but we wouldn't have to go pay for an additional cost.
Thank you. Thank you.
Other questions for Rory? If not, would you entertain a motion? Rogers first, Dorothy second. Question or discussion? All in favor say aye. All opposed, same sign. That motion carries. Thank you, Rory.
Thank you.
We are moving items C, D, and E to next time. Those are not ready today, so that'll take us to item F, Zelia. Consider approval of interlocal agreement for provision of pediatric with Nakona Independent School District. Who's taking care of Zelia's deal today? Pardon? Oh, she is, okay. There you are. Hi, Zelia.
Realize all those were going to be removed.
We
so
fooled you.
I was
We caught you.
patiently waiting my turn. Good morning.
Good morning.
Okay. I'm here today to present 3 contracts and request your consideration of these contracts. This is in regards to the T-Chat program that we operate through Senate Bill 11. The first contract for your review and consideration is an interlocal agreement for the provision of pediatric and adolescent behavioral health services between the Nakona Independent School District and the Tarrant County Hospital District.
Congratulations, you got one more. 3 more today, right?
2 more.
Fantastic. Any
Okay.
questions on the Nakona? All right, go ahead, we can
Okay.
vote on these all together.
The next one is approval for interlocal agreement for the provision of pediatric and adolescent behavioral health services between the Everman School Independent School District and the Tarrant County Hospital District. The third one is consideration of approval for an interlocal agreement for the provision of pediatric and adolescent behavioral health services between the Jacksboro Independent School District and the Tarrant County Hospital District.
That's great. So are you still working on more districts? We got more coming?
We do.
Fantastic.
We do. And just to let you all know, just a quick update, we've increased our volume since the last time I was before you, and we're close to 1,000 visits now. And I know the first time I came to y'all, I said we should be at 1,500, but I think we're going to surpass that. Just because of the great work of our acclaimed providers, as well as Tanisha Kennard and our outpatient behavioral health team. It's been amazing. I do want to share something that was really cool, because y'all recently awarded a contract for the Dublin ISD, which is a rural ISD, and they received their iPads, and we've connected them, and the school district emailed us back and said, we appreciate you so much and what you're doing for us and for this student. Your organization is making a difference for us out here in the sticks. We're grateful beyond measure for the service you're providing.
That's awesome. So they send you a case of Dr. Pepper with that?
Yeah, right. The good stuff.
Yeah.
Great.
How many school districts is this in total?
You would ask the one question. I don't know, Roger. It's a lot, and we also are.
And are we the only provider in these schools for this program?
We are.
Okay.
For many of these school districts, especially in the rural areas, they have no access to pediatric and adolescent psychiatry. So we're it, and they still, it's usually ages 6 to 18 that we see the most.
And there are no territorial boundaries as far as we can go across the state of Texas.
Well, so we're in Hub 11, and so we have 8 counties outside of Tarrant County, 8 or 9 counties that we are providing this service to.
Okay.
We're one of 11 hubs across the entire state of Texas.
Okay. Thank you.
Sure.
All right, questions for Z? Okay, have a motion to approve. Second from Z.
Janet?
Sorry, just one more question,
Yes, sure.
Trent, if you don't mind. Remind me, if you said it before and I forgot and I apologize, but if these children need inpatient services, do we coordinate that for them? Do they come here? Do we have room? Do they go elsewhere?
Great question. So in the most recent biennium, this legislature gave more money for Senate Bill 11, and so we got more money from the state, and so we hired 2 case managers strictly for the TCHAP program. And so the case manager's role is to care manage the kids from beginning to the end. And if the physician or the counselor believes that they need inpatient treatment, we try to keep them as local as possible for the parents to be able to participate. But bottom line is, if they have to come here and we find them somewhere, that's what we do as well.
Thank you.
Mm-hmm.
Great program.
Yeah, it is a great program. So this motion and second include the Nakona. Oh, you have a question? Sorry, Ralph. You got to yell at me. I just don't pay attention. Throw something.
Zillion, is there a report card that is available or that you have that shows the success of this?
We are keeping internal, like, tabs looking at the number of lives, the number of sessions that we complete, the number of referrals we make. So we have all of those. The state itself is still in the process with regards to consistent regulatory measurements and what those measurements may be. I will tell you that we have the lowest no-show rate across the entire state of Texas. We have a 5.6% no-show rate,
That's awesome.
which is amazing.
Good.
And that's the lowest across the state of Texas, and that's because of the quality of the counselors as well as our providers. They want to be seen.
Okay. I don't know how to go about this. Does the referrals, does the school teachers do the referrals?
It depends on how each ISD sets that up, but it could be the teacher making the referral, or it could be the guidance counselors making the referrals, or the parents requesting via the school for help.
Okay. The reason I asked this is I was in my third meeting on this in reference to the violence. And one of the determinants that appears that there's an agreement that a lot of the student violence is mental. And how do we get that child or somebody to see that there's that potential? A young man was killed this past weekend, just shot. I mean, in a parking lot, high school student, top athlete.
I saw
And so we're, and I'm just, I know they the group wants to sit, talk with you about what can be a process to address this.
Okay. Well, certainly, Rev, I'm happy to meet with you and your group and Dr. Duncan's, and anything I can try to do to help. I will say there's a huge movement throughout Tarrant County, and we've implemented it here at JPS. It's called trauma-informed care, because most kids today are experiencing trauma from somewhere, and if it goes unresolved, it can lead into bigger issues like impulsivity, uncontrolled anger, substance use disorders, mental health disorders, and those are going to get worse the older you get, where nothing is being treated.
Okay.
But I'm happy to help and at your service.
Yeah, I guess I'm just wrestling with, that teacher. How do they sense that there's a problem with that student? How to get them referred? Really, that's why I was late. There's a big situation as I speak taking place right now.
Really?
At Pascal High School.
Yes.
Major.
Yeah.
So,
Yeah, and Zelia doesn't talk about the other part of the program in which they actually work with pediatricians to recognize. So the training of teachers, the training of pediatricians, family medicine doctors to recognize this, ask the right questions when they see these children. So at every juncture that a child crosses, and even there are programs in which children identify other children. We've got to educate and help individuals be recognized, because often we don't know that we've slipped into a certain state in which we may be reactive with a poor outcome.
Correct.
So a
And
lot of
some
this
of-
program is about really reaching out within the community to begin to educate parents and teachers and pediatricians.
And some of the most successful programs are peer-driven. The Hope Squad that's run through the Jordan Elizabeth Harris Foundation, that's in many, many school systems across Tarrant County. They train ambassadors, kids, their peers. They train them to recognize signs and symptoms of depression and suicidality. And then those kids are the ones working with the other kids and getting them the help.
I think one thing that would be helpful if there's some kind of way the pluses for the program can be marketed citywide. I mean, just for individuals to know what's taking place. Some parent might say, hey, I need to get my child, just to know that this is taking place. I mean, we hear the pluses here, but how we get it from here outside.
Are we doing Fort Worth schools?
Oh, yes, ma'am.
Okay.
We are, one of our first contracts was with Fort Worth ISD. So we see Fort Worth ISD. We're also in contract discussions now, again, with Arlington ISD.
Okay.
So
When you tell me you're in contract with Fort Worth ISD, does that mean they got it in one school or two schools? Because they have a big district.
Right.
And so the problem I have is I don't know which schools have it, and it seems to me that they ought to be identifying the one that they're having the major behavior issues would be one that they would start with. But I have not heard that at their meetings.
Okay, all right. I'm happy to find out specifically which schools within Fort Worth ISD that we're in, and I can send that information.
So far, they have not mentioned they are coming to the community.
Okay.
So I'm just saying, when we contract with a school district, that does not mean that it goes to every school, so.
Okay.
Yeah, and hopefully the district is making it available in every school. In the district, I mean, that's the goal, but it's probably not happening. Yeah.
That's the goal.
To be willing to partner with this,
Right.
so to your point.
Even if they're not making it available, the district or the schools know it's available.
Yeah.
And that's the other
Oh,
problem.
right. Because that is not, they just came to my community talking about what they offered. That was not one of those for
Okay.
any of the schools that I'm familiar with. So
Okay.
that's my concern, that it's a great program, but if the
Rollout isn't done by the school system, it's.
Correct.
Yes.
Okay.
Right.
Okay.
I can follow up on that and.
All right.
Let you know.
Okay.
Happy
Any other
to.
questions for Zelia?
No.
Okey dokey, we have a motion on the table and we have a second. All in favor of the motion?
Aye.
Say aye. And sign, that motion carries. Thank you, Zelia. Appreciate it very much.
Thank you, everybody. Have a great day.
All
You
right.
too. Mr. Mendenhall here? Yes. All right, come on in, David. Is this the new protocol now? They all have to wait outside? I feel like we got him in the penalty box, especially him.
Because I'm going to be spending money as opposed to making
Always.
money. Always, yes, absolutely.
All right, David, take us away.
Thank you. So in front of you today is a contract between JPS Health Network and Worldwide Technologies. Worldwide Technologies is a hub firm that we use to purchase a lot of our equipment. They've been a great partner of us over the last couple of years that we've been engaged with them. The equipment that we're going to be purchasing here is for our Cisco switch networking in our outpatient clinics across the district, as well as our office buildings at JPOC. So the equipment that we're replacing is about 7 years old. It hit end of life last year, and that's why we budgeted for us to replace it this year.
So this is a budgeted cost, pretty routine. Any questions for David? All right, we have a motion and a second from Zim. Any question or discussion? All in favor say aye. Aye. That motion is approved. Thank you very much. And Adam, welcome, sir. This is Johnson
Thank you.
Controls.
Glad to be here. So I have two contracts to present this morning. The first one is for Johnson Controls and Company. It's for our building automation system for the towers for replacement of that. It is an obsolete system by a third-party vendor that can no longer effectually take care of the existing system. It includes main hospital, Trinity Springs, purchasing, procurement, laundry, and physical plant. These folks are self-performing, but they did bring in a hub participant to do the cabling. Of course, Johnson Controls is the best in class. Everyone knows Johnson Controls, and this is through our Vizient GPO. It is for $1.96 million. It is budgeted for this year. In fact, it's well under budget within the budget.
This was a function of proposals, Adam, or was it bid?
I'm sorry, I can't hear you.
A function of proposals, or was this bid?
It was a proposal because it was in the GPO. They're already pre-bid within Vizient.
Okay. Any questions for Adam? We need a motion. Zim. And second from Dorothy. Any question or discussion? All in favor, say aye. All opposed, same sign. That motion carries. Adam, thank you. Now, the contract with Byrne. Been waiting on this in a long time.
Yes, we have, and I'm very excited to present the Byrne Postel contract with JPS for $1.8 million. This is for a design build contract. This is the design portion. The build portion comes after the design, which will come back with a GMP contract value for that. Again, this was approved by the Planning Committee to move forward to Commissioners Court. The Commissioners Court selected Byrne Postel. This is 100% hub prime, and they have 36.8% hub in design. And we've already met with these folks, and we're already starting on design to get them down the path and negotiate the rest of their contract. So
What
we're
are you
moving.
thinking time-wise, Adam, on their completion of design? What are you thinking the time frame's going to be?
We think the design portion, I don't know yet, but we still think that we will be breaking ground in late fall, early winter. We're still on track for that. And since we're talking about it at PEC, we think we will be early fall sometime, so we're going to see something soon across the board.
Good. Very good. All right, questions for Adam? That wasn't a smirk of doubt, was it? Have a motion? Have a motion from Dorothy, second from Ralph. Any question or discussion? All in favor say aye. That motion approves. Thank you very much, Adam.
Thank you.
And tell Angie she can come on in now. What? Yeah. So much for germ spreading, right? Hi, Angie.
Good morning.
Like we hadn't seen you in a long time.
I'm a
You got some new
quarterly
glasses since the last
reporter.
time we see you. I like those specs. Those look good.
Oh, thank you for allowing me to give this report and taking your time to hear it.
You bet. We're ready.
Okay, so the first one on my list is JPOC 1400. It's brick repair. There were some loose bricks identified along the parapet wall at the top of the building. If you've driven down Main Street, you see a lot of scaffolding up, and the team is up there taking care of repairing that brick. It is a long process. We're doing a lot of hand picking just to help not to disturb. There's a clinic on that top floor, so we're trying to be as quiet as we can, but, you know, we're doing the best we can, and that'll finish up in August, and that's ongoing. The second one is a JPOC bridge repair. That's an actual insurance project back from when we had the freeze, and it froze some sprinkler pipes, which busted and damaged that, but it is being replaced. And this time around, we're not going with the wet sprinkler, we're going with the dry system. So in case we ever have a bad freeze like that again, we will not have a flood. So that's good, and the insurance agreed with that and paid for it, so we're happy about that. And I know everybody that's in JPOC, because there are vending machines up there that are hard to access with this project going on. It's going to complete tomorrow. So we'll be opening that bridge back up, and there'll be a lot of happy people after that. The third one is our X-ray room 5. Just about every time we replace any kind of X-ray equipment, it requires some type of construction. If the unit is heavier, if it's putting off more heat, there's just always something. So that's just routine work that goes with an X-ray replacement in our radiology. That should complete in July. The next one is our Jessica roof replacement. That is completed. We're waiting for the roofing manufacturer. They actually come out and do a warranty walk where they'll certify the warranty for that. It should be a 20-year warranty. But with a TPO roofing system, a lot of times you get 30 years out of your roof. So that was well worth the money. It needed a new roof, and that is done and ready for warranty. The next one, I just have to tell you, Mission Control. A lot of people excited about that because there'll be several different departments in there together, making sure the beds, we get the beds quicker this way. And that was a big project for us. And also, just as a side note, hopefully we did not scare Postel Construction off because this was their first project in the hospital. Yeah, so they've gotten through that. We're really happy to report that they did a good job and happy to partner with them on the medical home.
Great.
Mission Control, that is where if you can envision a lot of...
Yeah, exactly. Beam us up.
That's kind of a fancy name. No, they'll have a lot of monitors in there where they can see how the beds are opening up and if EVS needs to go clean that room and get it turned over, and it'll show them which beds they can put a patient in. It'll speed up the process for turnover is what I understand. I know Dr. Duncan or others could probably speak to that a lot better than me.
So it's an internal.
Yes, sir. Yes, sir.
Some kind of
No, not that one. We have a command center that they use. Yes, the command center for that.
Emergency.
Yeah. Yes, sir.
We're taking some things up to the moon.
Everybody's a comedian.
Projected budget and committed cost, is the projected budget the contract amount or is the committed cost?
The projected budget is what we're budgeted. The committed cost is what we've spent to date, what we've issued POs for. And, most of our larger contracts are the cost plus fee with the GMP. So if they didn't spend all the costs that they anticipated, we'll get a deductive change order, and that would be reported in the end.
Okay,
Okay.
thank you.
Yeah, sure. On the chiller install and thermal storage, I know last quarter, it's hard to remember, I showed y'all a picture of the brand-new chiller, so that is done. The next part is the thermal storage decommissioning, and we are working on the design for that right now. So that'll come back to y'all in the next couple of months. Finally, we have the central plant structural repairs. We can all be happy that those were done. We cut out a lot of concrete, asphalt, replaced it with structurally sound materials. That part is done. We do have a spin-off project that we'll be bringing back to y'all in the very near future on some electrical feed replacement that we'll need to do down there. But that's all I have. Are there any more questions? Yes, sir.
Yeah, Angie, back to on the bridge repair.
Yes, sir.
And you shared the dry system.
Yes, sir.
Explain that.
Oh, you know what that is? When you first hear about it, don't you think there's something dry coming out of there? It's not. It's a pressurized line, and you have a remote valve that's in a warm area that won't freeze. And when a sprinkler head detects heat or fire, it sends a signal to that remote valve to release the water. So you'd still get water, but in case we get a freeze, it won't release because that valve's in a warm area. Does that make sense? I'm trying to get you to picture it in my head.
Very much so.
Okay.
Okay, my question, I'm asking for personal reasons.
Oh, okay, okay. It was a tiny bit more expensive, but the insurance paid for it and thought it was worth it.
That's where I was going. It
Yes,
was
sir.
more costly.
It is a little bit more, yes, sir.
Okay.
But in the long run, it will be worth it.
But it needs replacing the gym floor.
Yeah,
Yeah,
yes.
I had that at my church. Took out my gym. Okay, all right.
I think it'd be a good idea.
Question
Look
for
into
Angie.
that for sure.
This has been a huge amount of work over the last year.
Oh, yeah, we're still
And,
busy.
Angie and Adam, that crew has done a great job. It's great to see that central plant structural repair is finished.
We're very
I was one
glad.
of those that walked through that and felt a little bit nervous, frankly.
Well, thank y'all for
Probably like some of the
approving everything.
pedestrians walking around JPOC, looking up and seeing bricks falling. So
Yeah.
I'm glad that we're getting those things fixed.
We are
Good
too.
job. And
Thank
as a
you.
reminder to everybody, none of this is bond funds. All this is your capital budget. So come back and see us.
I'll be back next quarter.
Keep us in line. We don't have to vote on this, but we appreciate it.
Thank you.
Come back and see us again. Thank you, Angie. So next item is the Planning Executive Steering Committee update. And most of you know at our last board meeting, there was significant discussion about what we do direction-wise in terms of accomplishing the board's purposes of re-looking at the priority of the capital relative to the bond program. That committee has met We met this week, a very, very productive meeting, I think, and I believe by our next meeting, we should have a recommendation, right, Karen? So moving forward with that, that will be, I know that'll be welcome news to everyone, and I was really happy with how the staff handled that. So a lot of flexibility and good stuff headed for us, I believe. And we have our next executive steering committee next Friday. So, which is okay, because the running events are on Saturday. I'm actually going to be able to be there. Thought I was going to have to miss it. Very good. Yeah. Happy to be able to be there because you were going to be right on tap for that. All right, so matters regarding action or approval. Derek, you have a whole bunch of these. Welcome.
Thanks for letting me be here. I'll go through this pretty quickly. So we've got, I'm going to let Derek handle that part. The better Derek.
Derek.
So we've got 3 RFQs that we want to move forward with to be released to put out for solicitation. Those are RFQs, and they're for the data center consultant, for the landscape architect, and for the acoustic consultant. And so we have a new data center that's going to be going in over on the east side of the campus. So this is something that's very specific, critically important. So there are consultants that we need to bring on, a consultant we need to bring on board to focus on that data center. Landscape architect and acoustic consultant, those consultants will be those that will be working on all of our projects, from the medical homes to inpatient towers, behavioral health tower, and all of our projects. So we need to bring them on board so that they can get started on Medical Home 1 and on the PEC project.
So we got all 3 of those. Okay, so let's pause at that because they're going to be recommendations after this point, right? So you've heard Derek's recommendations regarding a release of RFQ for data center, landscape architect, and acoustic consultant. We have a motion to let us go forward on that. Zim has a first, Dorothy second, or was it Ralph? Y'all can arm wrestle for it. Yeah, 2 first and a second, Lynn. Any question or discussion on that? All in favor say aye. All opposed, same sign. That motion carries. Thank you. All right, Derek. Now let's talk about awarding parking garage, Geotech, Cogen, and engineering standards.
Right. So these are ones that have gone through the process, through the JPS process. So we have solicited, we have shortlisted, and that's gone through the selection committee, which is part of the facilities team, part of a VP from that particular department, also has your diversity department is included on that. So those are team members that we get together, we review all the RFPs that get submitted, and so we have come to a point where we're ready to make the recommendation to move forward. The first one that you see for the parking garage is one that we are making the recommendation of 2 firms to move forward to the next step, which is to be reviewed and interviews by the county commissioners. So the 2 firms that we have making the recommendation from the recommendation committee to you is J.E. Dunn is the first firm, and the second firm is Beck Potiri. And those are the 2 firms that we have gone through the process, we have interviewed, and feel that they're very, very qualified firms. They've done a tremendous amount of parking garages, both of them, and are both very well qualified.
Okay, and this one will be one of those that goes to Commissioner's Court.
Correct.
And they will review that, and then we'll come back and ratify that. So any questions for Derek on J.E. Dunn and Beck as the 2 recommendations from JPS?
Derek, how many firms went through the process?
10. We had 10 submittals. And we were, and I can give you a little bit of detail, but some of the things that were really important was their MWVBE participation in both of these firms, especially, Beck has Potiri, which is in the prime, so they're in that prime level. J.E. Dunn has 100% participation in the design phase. So remember, these are design build, so they're bringing the architectural and engineering design company along with them into construction. So from the design side, J.E. Dunn had 100%, and Beck had 30% at the prime level. So both, and they both committed to having at least 25% once we get into the next phase of construction.
And what their score was.
There was, for J.E. Dunn was 98.
Okay.
For Beck was 74.
Okay.
Yes, sir.
Okay, other questions on this one for Derek so we can release this recommendation? If not, we need a motion. Okay, we have a motion from Ralph, a second from Dorothy. Any question or discussion? All in favor say aye. Aye. All opposed, same sign. That motion carries. And
Mark one abstention.
Okay, Roger abstain on that one. Leanne. Geotech.
Okay, for Geotech, Alliance Geotech Group, they are 100% minority participation at the prime level, and then they've got a commitment to 30%, and they have subs that are also going to work with them. And Geotech are the ones that are going to go out and do all the soil samples, borings, and things like that. So it's a very extensive amount of work that they'll be doing on all of our projects. So that firm was one that really stood out to us because they had the right level of engineers, testing labs, things like that were really important.
And this one does not have to go to Commissioner's Court, right?
No.
Okay, so this is one that we will award and move forward with. Any questions on this? Okay, we need a motion. Motion from Ralph. Second from Dorothy. Any question or discussion? All in favor say aye. Aye. All opposed, same sign. That takes care of our Geotech engineering consultant and now our Cogen.
For Cogen, we had making a recommendation of Jacobs. And Jacobs is going to be doing that out of their Fort Worth office and are very well qualified, done a lot of Cogen plants across the United States. So really strong firm.
And is this one going to Commissioner's Court or not?
No.
Okay.
The consultants that they want to see architect and engineer for specific buildings and parking garages.
Very good.
Yep.
So we can move forward with Cogen, subject to your recommendation. Motion from Ralph, second from Zim. Any question or discussion? All in favor say aye. Aye. All opposed, same sign. That motion carries. And finally, architecture and engineering standards.
And this would be Cogen is who we would recommend for this. Cogen is based out of Dallas, but very strong firm. Cogen was the firm that did the design work on your Northeast clinic, so they're very familiar with JPS.
Okay, you've heard the recommendation.
How many firms?
This one was fairly limited. I think we had one firm.
Is that right?
Yes.
Wow. Why do you think that is?
There's a lot of firms out there that, especially architects and contractors, that want to do the big projects here. And so I think some of them feel like, let's wait, and others feel like maybe this is an opportunity to get in. But I think that might be one reason. It is a lot of work. I know there's a lot of architectural firms that are very busy, so it takes a firm that's very adept and understanding healthcare, and so that would probably be another reason for limiting, because it's a lot of work versus going into, a design project.
So we will now negotiate a contract. How, roughly estimate budget-wise, how big is this, Derek?
We're probably in the 3 to 4 million range, I would estimate.
What I was thinking. Okay, any questions? Surprised that there only had one. Very surprised at that. Any questions?
Nah.
Roger's about to bust a button over there. You want to share or not?
I don't know. It seems odd that only one firm would apply for this, and I guess that's just surprising.
Oh, me too. I agree.
It's a lot of work for them, but really and truly, they already have the specifications written. It's in a book somewhere, and they just pop it into an overall plan. It's not like they're reinventing the wheel on a construction project of a hospital, of a medical home, of whatever. So I'm really kind of surprised. I don't have any particular problem with the potential awardee. It seems really strange that there was only one applicant.
Yeah.
So what are our options?
Yeah, we can either move forward, or we have to go back and re-release it.
I'm not sure my objections or concerns necessitate going back to the drawing board. It's a little bit shocking.
Yeah.
I mean, we posted all the things, gave everybody the opportunity, so. Yeah.
And for the selection committee, we have had a few that either for limited or due to some of the firms, we have gone back out. We felt the need to go back out. We've also, even through like pre-proposal meetings, we've seen that there hasn't been a good response, so we've done other methods of solicitations, but this particular one, we knew that it was a strong firm, a good firm, so that's why we decided to continue to move forward.
Good. Yeah, we're entrusting you guys, Adam, to make sure that if we get into a situation where we're looking at a single supplier and we have any doubts whatsoever about that, then I think we're asking you to come back and give us alternatives.
We moved two back out multiple times.
Okay.
Because we only had one. This proposal happened to be a very exceptional proposal. It was well-rounded.
Okay. Well, if the committee's comfortable, then we need to make a motion. Is that a motion, Roger?
Sure.
All right, I have a motion and a second from Ralph. Motion from Roger, second from Ralph. Any question or discussion? All in favor say aye.
Aye.
All opposed, same sign. That motion carries. Thank you. Do we have anything for executive session today? We do. Okay, so we will, yes, sir. Yes, sir, sure.
Angie made a comment. One of the things I would share that is taking place, and I don't know how we can, Derek walked out, I don't know how we can market it, but what is taking place based on our bond program, that you have joint ventures taking place.
Yeah, sure.
Which is a plus.
Yeah.
And so we're going to be able to see the diversity side met because of that, because Posterior joined Postel same.
With Beck.
There's been some fighting, but it's taking place. At least I don't get a million phone calls now.
Yeah, well, it's a very dynamic situation. I mean, groups that have not worked together that are now working together.
Yeah,
So
yeah.
part of that's mission accomplished, right?
Yeah.
That was our goal.
Right.
All right, very good. Well, we will go into executive session now. It's 11:20. What are we going to need? Daphne, is this your insurance thing today? The long away. no reportable items. And if there's nothing else on the agenda today, thank you all for being here. We are adjourned.